How many of you have not heard of Apollo 13? Great. What do you remember about Apollo 13? What's the first thing that hits you about Apollo 13? Yes, that's the first one. What's the second one then? That's right. Exactly. But absolutely. But that led to something which is absolutely relevant to Rice360 and what you guys will be discussing. What was the follow-up to that? That was an absolute engineering innovation exercise. They had very large constraints. I don't know what the exact numbers were, can't remember. They were very starved on power, and they had to bring the spaceship back. And a bunch of people on the Earth and in the spaceship brought Apollo 13 back. What's the big message is that you can bring the power of innovation, whether science, engineering, everything. You can bring it together to solve the biggest problems of your lifetime. That's the ethos by which, in Reggie's administration, we have a very strong focus. You guys know this much better than somebody like me coming from the outside, that Rice is a fantastic undergraduate university. Top 10, top 15, we could argue, doesn't matter. Our goal, we'd like to say top 10, but our goal is to have the same level of focus and expectation on our research. In order to do that, we went through a pretty elaborate process. We created a network of institutes and centers, and clearly the first one is the one led by Rebecca and Maria, who's unfortunately not here today. They are the stalwarts of this institute. They're the leaders of this institute. We have a network of such institutes focusing on 4 big topics. The first one of them is in energy. We call it sustainable futures, energy, environment, climate change. If you believe in climate changes, then it is important to focus on it. The second one is the focus of today's discussion is on health, innovations in health. And it has a network of institutes, prime among them being Rice360, that Rebecca and Maria are leading. We have one on cancer, focusing on, again, partnering with our colleagues here in TMC. One on medical humanities. We are very focused on solving the full problem, not just the technological or the science problem. The medical humanities is thinking about the human part of it. Mental health, for example. A lot of people talk about Alzheimer's, important, dementia, very important. But I think we don't pay enough attention to things like panic disorder. 20% of young people, my 2 daughters, both have panic disorder. They're still very functional, very smart people, but it shows up. 20% of the students in my class back at Berkeley, I used to teach a freshman class, they had some form of panic attack. We don't pay attention to it. But it is a solvable problem. So that's the second big focus, focusing on innovations in health. Our third, obviously, we have energy sciences, healthcare sciences. Third is information sciences. Not many people know this. The whole notion of parallel computing was started at Rice by Ken Kennedy. He's no more. He's passed away because of cancer. But Ken was a legend in the entire supercomputing business. And so we have a very strong AI machine learning, and we call it responsible AI, meaning we want to do it with a social conscience. And our fourth one is very strongly focused in the social sciences and humanities. And for all of you, I'm sure you know this, one of the kind of outcomes of Rice360 is hitting at disparities. There are a lot of disparities in the United States. If you go back to my home country, you go to Bombay, top 10 wealthy people in the country are in Bombay. 2 miles from there is the biggest slum in the world, Dharavi. And so you can see that we have this coexistence of the haves and the have-nots. How climate change impacts them is very asymmetric. How pandemics impact them is very asymmetric. So our fourth pillar is asking the question, how do I deal with disparities in urban environments? And Houston is a beautiful testbed, very diverse, very large world population. Cultures are different, social norms are different. So it's a good testbed to think about this. But it has huge implications worldwide. So that's kind of approximately our game plan. And Reggie, of course, is a wonderful fellow. He's our president. And so the focus is on doing scholarly work. And coming to Rice360, To me, Rebecca is God's cousin, or something like that. She's done some fantastic work. She'll continue to do work. I look up to her a lot in terms of doing big problems, solving big problems, using the power of engineering, the power of science. And so I don't want to take any, Yvette will probably give me snake eyes or something like that. So I want to wish you guys a fantastic conference. I'm hoping this will be an annual version that you will get together every year and ask the same questions. Are we doing the right things? Are we solving the biggest problems? In this case, in Africa, Malawi, for example. Are we really doing the best, not just for Houston, not just for Texas, not just for the United States? We should be doing the work for the world. One of the big focal points for Rice is we need to be in equilibrium with the world. And actually, we have this joke. There are a couple of things about Rice. We have this thing called behind the hedges. You can see there's a lot of beautiful trees here. And that's kind of an understatement here. And so I jokingly pushed Reggie. I said, Mr. President, take down the hedges. You guys know the other statement that Ronald Reagan made. And so we want to be in equilibrium with the world. We want to be useful to the world. We want to be known around the world. And 360 is perhaps the best example of that. With that, I will give it back to Rebecca. Thank you very much for letting me share what we are planning. We're happy to take questions, happy to take feedback, criticisms. All of them are useful. Thank you.
Well, thank you so much, Ramesh. We really appreciate your support for Rice360 and also for making this meeting possible. It's really wonderful to have all of you here today with us to talk about how innovation can make a difference for moms and babies at the beginning of life. And we've been looking forward to this conference for a really long time, but a lot of people worked really hard to make it possible. So I'd like to just ask for your appreciation of the Executive Organizing Committee and the staff who worked so hard to put this on. Can we just get a round of applause for them ahead? I think it's also really important to acknowledge your inspiration. And I want to ask how many of you ever participated in a Saving Lives at Birth meeting that was organized by USAID? I know we have some alums of that program. I am an alum of the Saving Lives at Birth program. It started, I want to say, in 2011, and it ran for 8 years. And it brought together a wonderful community of innovators, clinicians, people from the private sector, people from NGOs that were all working to develop and translate innovations that could make a difference. And it was kind of like science fair for grown-ups. You submitted an application for a proposal, you brought your innovation with you, you had to stand up and give your 1-minute pitch and talk about how your innovation was a game changer. And then literally at the end of the meeting, you found out if your proposal was funded or not. It was super stressful. It made me a lot more sympathetic when my kids were going to science fairs. And as I was driving to work this morning, I was thinking about what is it that we take away from science fairs? We take away that science is done by a community of people who come together to talk about that science and to talk about how that science matters, how that science can make a difference in the world. And in coming together, we find inspiration and community. And hopefully we leave inspired and having learned how to do our work better and how to do our work more effectively. So my hope for all of us in this room is that we all leave with that feeling of inspiration that I used to leave those Saving Lives at Birth meetings with, and that we're energized to continue working together as a community, doing science that really matters, that really makes a difference. So I'm really looking forward to the next 3 days of that. I'm going to go ahead and turn it over to our Executive Director, Yvette Maribel, to kick things off. Yvette?
I'm going to take the podium. Thank you, Rebecca. Thank you, Ramesh. Good morning, everyone. As Rebecca said, my name is Yvette Maribel. I'm the Executive Director of Rice360, and it is my distinct pleasure to have the honor of kicking off the first session of this conference on maternal health innovation. Maternal health, the period from during pregnancy and childbirth to the weeks and months thereafter, is widely considered a key indicator of society's well-being. And when we look at what's happening in the world, we should all be greatly concerned, both locally and globally, that maternal deaths remain unacceptably high. America has the worst maternal death rate of any developed country, and Texas ranks 8th worst state for maternal mortality in the United States. Globally, more than 250,000 women die during, following, and in childbirth each year. Between 2000 and 2020, there was progress. The deaths from these complications during pregnancy, childbirth, and in the postnatal period did decline by 35%, but the progress, the rate of that change was too slow. Current projections show that we will still be more than double the SDG goal that we have set for ourselves as an international community by 2030 at the current rate of progress. And what's more than that, it also hides the disparity, the inequalities that exist within and across countries. More than half of maternal deaths occur in fragile and humanitarian settings, and sub-Saharan Africa and Southern Asia have the lion's share of maternal deaths, with more than 85% of those deaths. Our 3 speakers today really represent the entrepreneurial, clinical, and engineering perspectives that must come together to achieve innovation needed to make those strides, that make that change to really achieve that goal, and faster than we've been doing it. Today we have Tore Laerdal. He's the executive chairman of Laerdal Medical, the global leader in resuscitation training and therapy products. Laerdal Global Health is a nonprofit affiliate of Laerdal Medical, which provides affordable products to help saving lives at birth in poor countries. Laerdal is an example of how linking business to wider societal goals and purpose can create exceptional results for both business and society. Amy Cannon is a maternal and newborn health advisor with Jhpiego and a practicing NICU nurse in the Washington, D.C. area. She has deep experience with working across humanitarian and development settings, working on maternal and newborn health programs, specializing in innovation for small and sick newborn care, and the mother-baby Dyad. Juliane Sempionatto is an assistant professor at Rice University. She has experience in developing wearable electrochemical sensors to monitor medically relevant biomarkers in sweat, saliva, tears, interstitial fluid. Her research interests include soft and stretchable electronics, high-performance electrochemical biosensors, and biofuel cells, which are the sort of things that could really help mothers. So I will invite Tore up here first to join me. After Tore speaks, and after each of the panelists speaks, or plenary speakers speak, we'll have a chance for Q&A. Thank
you.
Thank you.
Good morning, everyone. It's my privilege and honor to be the first plenary speaker at this very exciting conference. I apologize a little for my voice this morning, but I do hope you can hear me. So I've been asked to talk about the mother-baby Dyad, and let me first allow me first to say a few words about the word innovation, because this is the title of the conference. And innovation is a word that everybody uses very often, but not necessarily have the same understanding of. Innovation, I think, is typically associated with breakthrough research or new technology, exciting products. But I would argue that innovation is all about impact. And unless these products come to good use and make a difference, innovation hasn't happened. So innovation, said in another way, is more impact for the same resources. And in all resource settings, of course, the resources are very limited. So we're seeking solutions that can give a better for a better result for the resources we have available. One way of explaining this is the metaphor of the formula for survival, which is suggesting that survival, the chances of survival may be expressed as the product of 3Ds, discovery, the quality of the discovery, times the quality of the development, times the quality of the delivery. And in a theoretical model, one could assume that all of these were absolutely the best thinkable quality. So we had 100% efficiency on all 3Ds, and we end up with hundreds, or 1 times 1 times 1 equals 100% of the theoretically possible survival or innovation, impact. Ideally, perhaps one could speculate that one day it may hopefully be possible to achieve, let's say, 90%. And we see, since this is a product of 3 factors, we don't end up with 90%, but 72% efficiency or innovation or impact. And perhaps, and this is, of course, very, very, very soft speculations, but I think there is a growing understanding that the weakest factor of these is the implementation of knowledge we have or the delivery. So if, for sake of example, we had 80% quality of the discovery, 50% of the development, and 25% of the delivery, we're ending up with 20% instead of 100% innovation. I am very much looking forward to hearing the status of several of the 120 innovation projects that were awarded a seed grant or a translation to innovation to, or translation to scale grant by the Grand Challenges Saving Lives at Birth program that was started around 2012, I think. And here is an evaluation report by Duke University, and that's of the 1,200 in hindsight as this program was over, and they made 3 top recommendations. Define more precisely the publicly key Saving Lives at Birth program goals, strategy, and success metrics over time. So the time element is stressed. Strengthen proactive engagement and buy-in of public and private sector stakeholders in priority low medium income countries, and address continued gaps beyond current Saving Lives at Birth program support in order for innovations, and here's the word again, to scale sustainably. So all of these 3 recommendations, I think, has a reference to the time factor, and for innovation to happen, it needs to be sustainable, it needs to have delivery impact. I started with a very nice picture of a smiling mother and a healthy baby. Unfortunately, the situation is not always like that. There are some 6,000 babies dying every day, and some 800 mothers dying every day. These are numbers that are difficult to relate to. They are so enormous. And the SDG has set a goal to reduce them by 2/3. And we are not nearly there, as I will revert to later. This is a often shown illustration resulting from research by Dr. Buttu and his group. It shows or stipulates that there are 2.6 million preventable deaths at birth every year. The interesting thing is the, I think, distribution of these bars, because it shows that 50% of these deaths, preventable deaths, occur on day one. And at the bottom, you see the maternal deaths, and they, more than any of the other categories, are focused on or happen on day one. They are not as many, but there is a very close relationship between the mother surviving and the baby surviving, and therefore this title also, the mother-baby dyad. Now, if we look at, sorry, this is going a little wild here. If we look at the causes of newborn deaths, to start with, this is how they are typically reported. In a pie diagram, stipulating that preterm deaths make out 37%, intrapartum, or often referred to as asphyxia, 28%, and infections 24%. But I would argue this is not a very accurate way of presenting the situation, because as is highlighted in this report from UNICEF and WHO, preterm deaths make out 67%, and low birth weight 80% of the deaths. So how is this possible? Can both of these diagrams be accurate? And I would say no. The situation would much better be illustrated in a Venn diagram, because 67% are preterm, but 50% of these preterms are also asphyxiated and need help to start breathing. So the pie chart to the left is really not the best way to illustrate this. It's a multifactorial problem, and it needs, therefore, integration of programs to deal with these issues. And there is a very good reason then to why the preterms are particularly in need of helping to start breathe, and also immediate KMC. That is also why there are strong synergies between the Nest 360 program housed here at Rice and the Safer Birth program that I will speak a little about, which is happening in Tanzania, and also the Saving Little Lives program in Ethiopia. Because if you can save a baby on day of birth, and if you can help that baby to start to breathe, some of these preterms don't need to arrive in the NICU. Others will arrive with a much better condition. And therefore, it makes a lot of sense. And I'm pleased to say there are good ongoing discussions to combine some of these programs. We, the Laerdal Foundation, which I'm also representing, entered in a collaboration with the World Bank and its global financing facility. This is a busy slide, but that resulted in a call for proposals for innovation to scale at a later stage of scaling. And in blue to the left, you see the same metaphor of the 3Ds making out the impact. And to cut a long story short, the Safer Birth program in Tanzania ended up being one of the 5 award winners. Saving Little Lives in Ethiopia, another one. And you see that these vertical lines represent typically 3 to 4 years a period. And many programs start out in the seed phase, Some go to translation to scale, fewer go to innovation to scale, and very few end up with national scale-up. So for innovation to really happen, we need to look at how can this continuum of innovation take place. And the Safer Birth program and these other award winners met the core criteria of being proven concepts, quality of execution and evaluation plan, local organization, strong local ownership by the government and team capacity, and again, well integrated with Ministry of Health strategies. So this was in 2020, and I can now report on 3 years later how this Safer Birth has developed and what results it has given. Here we have the same timeline from 2010 to 2030 at the bottom. And many innovations really take somewhere from 15 to 20 years to really scale up nationally. Many of them don't survive that process. And unfortunately, in countries with low resources and more confounding factors, that timeline is often longer. So what may take 10 years in the US or in Norway may take 25 years in sub-Saharan Africa. And of course, if one could truncate that, that would be innovation, if things can happen quicker. Anyway, the story of this Safer Birth, and I also put in Saving Little Lives in Ethiopia, started with helping babies breed and helping mothers survive, the Survive and Thrive, a global development alliance. And then came the DFF, Innovation to Scale. And this is now continuing with a additional scale-up. And we are very optimistic that we will see a full national scale-up based on the results that this has delivered. On the top line, you see who is typically funding these steps as this 20-year process goes. So it may be innovators, again the word, developers, NGOs, foreign aid organizations, professional associations, and then in the later stage comes GFF, UNICEF, WHO, and ultimately the Ministry of Health. So the title of this slide, From Donorship to Ownership, is quite important. Because unless it is really owned locally and proven to have a cost efficiency that merits being integrated in the Ministry of Health programs, it will not be sustainable. So this Safer Birth bundle of care is, by good margin, I believe, the largest day of birth study ever. It comprises 350 births that are prospectively observed and analyzed. 1,700 newborn resuscitations are video recorded with absolutely full monitoring. And that has formed the research data for many of the 28 PhDs that are completed or still ongoing, half of them by Tanzanian doctors, and 140 peer-reviewed papers so far. This is well on the way to 250, I believe. And the findings of these studies have informed the next iteration of this program. So it's been an iterative program for now 10 years. And the innovations, if you like, and I again apologize for some inconsistency in the use of the word innovation here, but devices that have been developed are really in response to the findings of the studies that have been ongoing. So 4 products have been developed as a result of this. Neonatally live, because babies that are not breathing, they have a fluid film lung. They have a totally different lung compliance than a typical CPR mannequin made by us and others. So we needed to make a adjustable lung compliance that represented the cases that you could have. Otherwise, there would be a high risk of trying to ventilate and the air went out the pressure relief valve out in the room instead of into the baby's lung. Moyo is a fetal heart rate monitor that replaces the Pinard stethoscope, which is a 150-year-old technology, which is still the dominant way of monitoring fetal heart rate. But Moyo captures the fetal heart rate in a tenth of the time, in 6 to 7 seconds, and it stores the data for both to advise the clinical personnel, but also for quality improvement and monitoring. Neobeat is a similar device that replaces the regular stethoscope, also an over 100-year-old technology, with the same way of capturing in a digital manner the data, which allows for totally different sort of quality improvement follow-up. And there is an upright bag. So this is one of the 8,000 babies, unfortunately, that ended up dying, but this was a stillborn, or at least they were classified as a stillborn. But 25% of the stillborn, 2 million stillborns per year, they have 50%, excuse me, 1 million of the 2 million have a beating heart during labor. And half of them, again, that is a 25%, 500,000, are considered to be possible to save if there is really an awareness of these chances. So there are ignorance today, and they are put aside because there isn't a detection of that heartbeat, and the baby is believed to be dead when it's not. Helping Babies Breathe started out in 2010 and has reached, we believe, 900,000 birth attendants in 80 low-resource countries. For many years, we were very proud of that number, but it's not a matter of the reach. It's a matter of the competence. It's a matter of really what is being done to the baby in a clinical situation. And that is what has come out of this ongoing research. But as we made with American Academy of Pediatrics, with JPIGO, with USAID, UNICEF, and a number of other partners, these programs, it was obvious that if Helping Babies Breathe could reach the birth attendants, then that offered a chance to make a very similar program for helping mothers survive. And that's, and here you see a training situation with bimanual compression to stop a postpartum hemorrhage. So, as we heard in the introduction, we are far from being on the way to reaching the target goals for neonatal mortality, and even more so for maternal mortality. This report from Gates last year estimated that the maternal deaths per 100,000 live births is 151. The goal is 70, and that there has been no improvement since 2015. And this reported up until sort of midway into the COVID period. And actually, there has been a 40% increase in maternal mortality in the United States. And we see these predictions by Gates. The blue is the likely trend with the current initiatives taken. And we are very, very far from being on the way to the reaching the 70 deaths per 100,000 births in maternal. You see the likely projection is 138. So, Houston, we have a problem here. Now, there are some data comparing to this, which is a little more optimistic. This is showing the results, and I have to stress here, this is unpublished preliminary data. So I ask you not to take photos of this. It is in final review in a prestigious journal. But this is showing in vertical lines when the 5 regions in Tanzania enter this program. And there's a baseline of around 100,000 deliveries. There is a post-intervention data for 250,000 deliveries. And during this period, the newborn mortality has been reduced by 45%. Even more encouraging is the maternal mortality, which on this preliminary data is down 70% on 250,000 deliveries. Now, these are amazing numbers, and they may be difficult to believe. So let me try to explain what is making this possible. Let me show a video.
In Tanzania, the Safer Birth Band of Care program is helping to reduce maternal and newborn mortality. It's also changing the way people work, with weekly simulation training and debriefing and the use of data for quality improvement.
Mradi huu umetuletea kitu kinachoitwa low dose high frequency. Kwa jambo hili limetujengea sisi watumishi kuhakikisha ya kwamba tuna adapt skills lakini na knowledge ambayo wametuletea kwa ajili ya kumsaidia mama pamoja na kumsaidia mtoto.
Weekly analysis of training and clinical data enables healthcare personnel to identify gaps and make improvements.
Kila wiki tunafanya mazoezi katika wodi yetu. Namna tunavyofanya kitu cha kufanyia mazoezi inatokana na cases tunazokutana nazo wodini, labda kama PPH zimekuwa nyingi au resuscitation za mtoto. Kwa hiyo hizi zinatusaidia kujua ni skills zipi ambazo labda baadhi ya watu wana shida nazo.
Tunafanya quality improvement kila siku katika kituo chetu. Kama kuna changamoto niweze kuitambua na iweze kuitengenezea action plan.
Imekuwa ni tofauti sana kama zamani. Mradi wa SBBC umetuletea kitu kinachoitwa no blaming culture. Tusiwe na uwezo wa kumlaumu mwingine, lakini tumsaidie juu ya pale ambapo ameshindwa kufikia uhitaji wa utoaji wa huduma.
Sehemu kubwa ambayo inanifurahisha ni namna tunavyofanya mrejesho, tunaita debriefing. Sehemu hii imetusaidia kwanza sisi wenyewe tunapokuwa tunafanya haya mazoezi, namna tunavyopeana mrejesho, mtu anakuwa haoni shida kuleta zile changamoto ambazo amekutana nazo, lakini pia haijaishia tu kwenye upande wa kufanya simulation, pia hata namna tunavyofanya discussion zetu. Zamani tulikuwa tunaangalia tu vile vitu ambavyo havikwenda vizuri, lakini sasa hivi watu wana focus pia kwenye vitu vyao ambavyo wameweza kufanya vizuri, ambayo inatusaidia.
So, in summary, this is the concluding slide of a keynote presentation at the World Congress of Patient Simulation, IMSH, that was held in San Diego in January this year, of the principal investigator of this global research consortium that now contains over 200 researchers. What saved mothers and babies in the Safer Birth Bundle of Care program is local ownership from early planning through implementation. Local champions to drive in situ team training and culture change. And you saw these midwives talking about getting rid of the blame and shame culture. That has been a big problem in particular for stillborn. And the interesting thing, the hypothesis was that there would be a reduction also in stillborn, but the absolute number of stillborns have gone up. And why? Because there is more discipline in reporting them. So there are more stillborns, fewer percent die, but the absolute number go up as a result of discipline in reporting. All right? Data-driven continuous QI. This is now scaling up this program with a round 2 funding from the World Bank to 150 hospitals, covering 25% of the population in Tanzania. And all of these hospitals are receiving a dashboard weekly on their performance. And we can look any time of the training activities, and they're doing 2 in situ trainings per week, and they're doing a daily test on the neonatally live on average in these 150 hospitals. Ongoing mentorship and supportive supervision, and systems for equipment maintenance and reprocessing. So, thank you very much. I'll be pleased to take any questions.
Hi, my name is Joshua Bress. I'm here with Global Strategies. Thanks for the great presentation. My question is about those innovations that never made it, and specifically around neonatally live. How much do you think it helped that it was built in a company that was already making other products? Something I've observed is that many of these are sort of products without a company and pilot projects by design.
Yeah, that's a good question, and I think it takes it takes a system to save a life, and it takes a system to develop a new product as well. And I think it takes a combined system of clinicians, researchers, quality improvement people, and passionate companies to end up with the best results.
I had a question about sort of the last part of your presentation with the video and the collaboration and the QI and the shifting of the culture of blame. And I think my question is, how much, if any of that, had to be involved sort of like with any sort of like legal change and in Tanzania that made people feel safer to have those conversations, if any? And is that sort of a missing piece of delivering good healthcare, is bringing those people to the table to help create those safe environments also from a legal perspective for healthcare workers?
Yeah, that's again a fairly challenging question, I think, but it is a system, as was tried to summarize in this last slide, and it takes a very strong support both from the Ministry of Health, from the administration of the hospital, from the champion in the hospital, and from the data collectors. There is more to this than the presentation time allowed to present, but there are gaming features here, there are leaderboards, there are reports back where they can really see what is happening. And these hospitals, on average, had a maternal save every 6 to 8 weeks. And that's very, very visible saves. And what I didn't talk about is that for every mother that dies, there may be 10 that are disabled. So the impact, not only in life saved, but in quality of life saved, is very, very significant. So there were, in this first phase that counted 30 hospitals, now it's getting up to 150, there were extra investments in data collectors, in doubling up on local champions to secure the data for the research, But it's very, very encouraging to see now that when it's now 6 months into the scaling up to 150 hospitals, the training activities have not gone down, it's actually increased further. And we think that the closed circle where really data are fed back on a weekly basis to all of these hospitals is very, very important for the motivation.
Thank you.
Good morning. I'm Anita Gardine. I'm the Chief Development Officer with Global Strategies. I'm with Dr. Josh, who spoke. You know, from our work in DRC Congo and also in Uganda, we see a lot of babies and moms who just don't make it to hospitals. So by the time they arrive, they're in even greater stress. We also see lots of turnover and maybe not dedicated staff in a neonatal or maternity unit. So as additional tools are developed to help folks in those real-world environments be successful, such as the clinical device, clinical support system tool we've developed to help respond to that turnover, it's not an open source tool. As you talk about that ability to scale, and we're excited to scale past the 100,000 uses in 41 hospitals, how do you achieve that when you don't have an open source product because you've had to design a tool effective in a different environment?
Training is not resulting in clinical impact if it only takes place once and out of the clinical situation. So the ongoing refresher training is extremely important, both for this competence to remain, and secondly, to also pick up the rotation of personnel. In Safer Birth, and I believe you have similar experience in S360, there is a challenge in the rotation of the personnel. And midwives, they typically work for one period in the labor ward, then they work with vaccination or with antenatal visits or other things. So you may come back to the same hospital after 6 months and half of the people you trained are new. So there needs to be a system to address that, and this low-dose, high-frequency, simulation-based, peer-led training is a very, very important part of this program.
Thank you. As a second comment, I want to thank you for your work through your Global Health Foundation and for every innovator in the room. October 1st is the deadline for grant submission, 30 to 50,000. We're already in progress, so for folks who weren't aware of that, encourage you to pursue it. Thank you.
Thank you.
For your time.
Yes, Mark Ansemino from the University of British Columbia. Tor, thank you very much for a very inspiring talk. I think that one of the issues that you sort of touched on that I just really wanted you to give some input in, which is really around the maintenance of innovation. So what you've described here are programs that are still very innovative where you're actually going. But of course, you're going to reach a plateau somewhere where you can no longer get this additional funding and everything. How do we, and you know in the world today, most of us in healthcare don't work at the edge of innovation. We work within real environments. How do we sustain this? And particularly in low resource settings, how do we convince people to invest in the maintenance of these innovations?
This from donorship to ownership sort of process. And we believe that the only way you can have a sustainable long-term impact is to prove beyond doubt that this program is so cost efficient that it deserves to be included in Ministry of Health led programs because it's a better return on investment than alternatives. And also, if it's sufficiently effective, then it would, as in this case, qualify for being included in an investment case. The Global Financing Facility has, under the World Bank, has 36 member countries. And there has been a very deliberate effort in this program to document it so thoroughly that this could be a solid case to be studied by the World Bank and the Ministries of Health in the 35 other countries. And I'm pleased to say that there is strong interest of adopting this program in 2 more countries now.
Very excited to be able to spend the next couple of days with you at this really exciting conference. Today I'm going to talk about accelerating uptake of impactful maternal newborn health innovations. I'm going to give 3 examples of innovative technical strategies, 2 that are service delivery models and 1 that's a product. And I'm going to talk about some of the key factors that have contributed to accelerating uptake of these innovations. So as was shared earlier, I'm a maternal newborn health advisor with JPIGO. JPIGO is a public health nonprofit that's affiliated with Johns Hopkins University, and we partner with ministries of health and various local organizations to strengthen the delivery of healthcare services. We currently implement 60 maternal newborn child health programs awards across 28 countries, and JPIGO has led large USAID maternal newborn child health flagship awards for the past 25 years, with the current award being the Momentum Country and Global Leadership Award. And you see on this slide kind of the path that JPIGO has had through these global USAID flagship awards. Throughout all of these awards, JPIGO has always placed an emphasis on innovation as a key priority. And just before I get started, because I always find it interesting and telling to understand who's speaking to me, I'll also give you just a little bit of background about myself. I work across maternal and newborn health programs for JPIGO. I have deep experience working in technical design, monitoring, evaluation, and research, which spans both humanitarian and development programs. I'm also a newborn intensive care unit nurse, and it's important for me to keep my practice current. So I bring the realities of clinical practice into my work. And lastly, I just want to mention that JPIGO serves as the secretariat for Align MNH, which is a knowledge sharing platform that cultivates country-to-country knowledge sharing around the mother-baby dyad. So working under Align MNH last year at the International Maternal and Newborn Child Health Conference, I led the maternal newborn health technical marketplace event, which brought together 55 innovators through an application process to display different products and service delivery mechanisms. So I'm excited to be back amongst you instead of the innovation space today. We know that globally, every 2 minutes, a woman dies during childbirth or pregnancy. We also know that progress in reducing maternal mortality has stalled in the last 5 to 10 years, as Tor was telling us, and that progress to meet the 2030 SDGs is off track. So what are some of the innovative technical strategies to help us bring down maternal mortality? JPIGO has a long history of testing the effectiveness, acceptability, and feasibility of new innovations in low-resource settings and exploring and addressing the barriers to uptake. I'm going to highlight just a few of these innovations today, but I would have loved to highlight kind of like the greater gamut of all the innovations that are showing some promise, but I'm going to just pick out 2 or 3 of these. But I'd invite you to kind of take a look at what the other ones are here, and please approach me throughout the week with conversations if something else here speaks to your work or your interest. So we so often think of innovations as products, but it's important to remember that we have service delivery innovations as well. So the first innovation I'm going to highlight is group antenatal care. So every woman wants a positive pregnancy experience. Women want to remain healthy and they want a healthy baby. But the reality is that antenatal care services in many low-resource settings just often can't provide the quality care that's needed. And we know that women often begin A&C too late, they don't return for the recommended visits, they miss opportunities for continued care such as skilled provider delivery, postnatal care, postpartum family planning. Waiting times at A&C clinics are often too long, and interactions with A&C providers are often too brief. So group-based A&C, or antenatal care, is an innovative service delivery model where women of similar gestational age receive A&C together in a group throughout their pregnancy. This is still ANC, it's just a different service delivery model. Group ANC mimics the WHO ANC model to provide 8 visits for women. When women come for their first ANC visit, they're invited to join a group of 8 to 12 women of similar gestational age, and then they return for subsequent ANC visits on scheduled dates and times as a group, with the same women and the same facilitator every time. Meetings are held at the health facility, so it's not a community-based model, and they include self-assessments with the help of peers, individual assessments by a provider, and facilitated group discussions and activities. And the model has really, it means it's met a lot of women's needs for information, for relationship with providers, for respectful care, and for peer support. JPIGO used the core principles of Group ANC. We adapted materials to local contexts, and we've implemented Group ANC in 10 JPIGO countries. The successes of Group ANC can be demonstrated in a program JPIGO implemented in Nigeria between 2021 and 2022, and you see the data here from that. Over 176 facilities adopted Group ANC as the predominant model for ANC, and they enrolled over 39,000 women. As a result, as you can see in this graph here, the facilities collectively had large increases in the number of women attending 4 ANC visits, 8 ANC visits, the number of pregnant women receiving at least 3 doses of intermittent preventative treatment of malaria, the number of facility births, and the number of women receiving postnatal care within 72 hours. Group ANC is really a story where countries have taken to scaling up this intervention on their own. So this slide here shows you that this is not JPIGO's work, but kind of the broader Group ANC and where this intervention has been taken up. So you see it's been adapted and implemented in nearly 30 countries, and published research results continue to show a continued positive association with increased retention in ANC and improved quality of care for women. And you see also just a mention here of Group PNC with the asterisk here. And I wanted to just mention this is one of those that I would have loved to go deeper into, but there's new evidence and pilots coming out on Group PNC and sort of how we can adapt the Group ANC model, including some interesting research that I'm doing actually in Nepal right now with a cohort of small sick newborns that were discharged and their mothers, and sort of Group PNC after discharge. So why is there so much excitement? Why are countries scaling this on their own? Group ANC reorganizes how care is provided, and it's showing to improve relationships. It's been shown to increase the quality of care, the uptake of services, and it empowers women and it empowers providers. It's resulting in better learning for women, better experience of care, and higher job satisfaction for healthcare providers. Lastly, Group ANC also creates opportunities or a platform for integration of other high-impact innovations and programs. It can advance innovation with new devices and drugs, such as point-of-care ultrasound, as JPIGO's done in Malawi, and for prenatal vitamins, MMS, as we've done in Mali. It can also be a future platform for new vaccines or a way to address things like perinatal mental health. Through funding from the Bill and Melinda Gates Foundation, JPIGO organized the first ever global Group ANC meeting earlier this year. It was a 3-day event held in Kenya, and it was an exciting opportunity that brought together 130 participants, mostly from low-middle income countries, all with experience implementing Group ANC in their countries. And the purpose really of this meeting was to catalyze broad adoption of Group ANC and other group care methods. The group worked on a final roadmap with an advocacy plan and prioritized a research agenda, and all of this is coming out soon. The next innovation that I want to highlight is emotive. And I want to just bring your attention to the picture here. You see a drape in Kenya. that for measuring blood loss. And this particular drape was an innovation made from the Melinda Sub-County Hospital midwives. It's a sheet stitched using a pedal sewing machine by a local tailor into a drape funnel, which then goes into a stainless steel basin with internal calibrations for measuring blood loss. The drape can be easily disinfected using a 3-bucket disinfection process. It's cost-effective at around $15 US, and it receives positive feedback from healthcare workers that use it. I'll talk more about how this and other similar drapes that are being developed in different countries are part of the emotive approach. Postpartum hemorrhage is the #1 cause of maternal deaths worldwide, despite the fact that death from postpartum hemorrhage is largely preventable, and we have evidence-based guidelines for prevention and treatment. PPH, or postpartum hemorrhage, is defined by the WHO as losing more than half a liter of blood within 24 hours. Some of the challenges to preventing and treating postpartum hemorrhage are that the treatment is often delayed or not detected, that there's inconsistent access to and use of interventions, and also that the quality of uterotonics and availability of drugs is less than optimal. So Jhpiego was heavily involved in the research for the emotive study, which provided strong evidence for early detection of PPH and a complete bundled approach for PPH. So what is a bundle? I think Tor talked about bundles as well. So a bundle is a structured way of improving the processes of care and patient outcomes. And I want you to think as I go through this particular bundle, what might there be other ways that we can bundle evidence-based practices together to make them more effective? So emotive stands for, the E stands for early detection, and these are the parts of the bundle. Early detection is quantitatively measuring blood loss, and this is the part of emotive that's meant for every woman. So every woman, through the use of a drape or whatever makes sense in that context, is what the E stands for. And then that will trigger the rest of the emotive acronym here, or MOTIVE, which is actually the WHO first response bundle for PPH. So the M is for massage of uterus, O is for oxytocic drugs, T is for tranexamic acid, IV, and examination and escalation is the E. So the emotive study was a multi-country cluster randomized trial. They evaluated the bundle that I just presented, and it included the use of a low-cost drape to quantify blood loss. It took place in Kenya, Tanzania, Nigeria, and South Africa. And there were 40 facilities that were randomized to the intervention emotive bundle group, and then 40 that received continued normal care per usual. The study results, which were published in the New England Journal of Medicine in 2023, demonstrated that postpartum hemorrhage was detected in 93% of the intervention group and just 51% of the patients in the usual care group, which reflected the efficacy of using the drape for providers to objectively see the amount of blood loss. Early detection of postpartum hemorrhage and utilization of the emotive intervention led to a 60% lower risk of the primary outcome of the study, which was severe complications of postpartum hemorrhage. The emotive study demonstrated a real turning point for the implementation of a low-cost clinical bundle that could dramatically reduce the number of women globally dying from PPH. And it prompted important changes in policy and practice, which you see reflected on this slide. So a roadmap to combat PPH and a call to action was released in 2023, which provides a global strategy to address PPH. It aims to align efforts among partners working in the PPH space to deliver PPH agendas. The trial results have also prompted renewed interest in some donors to focus on PPH, such as through the Unitaid-funded Amplify project, project, which is a consortium Jhpigo's leading with support from FIGO to introduce quality-assured PPH medications to low-middle income countries. Lastly, the WHO revised its guidelines on PPH management, and countries are updating national guidelines on PPH care and management. My final point that I just want to say about emotive is that while emotive is life-saving, it needs to be embedded within holistic PPH care to make a difference. I think, we often get attracted to silver bullet innovations, but if you invest in silver bullet innovations and not holistic care to support these products, they will most likely fail. What will really make the difference is a comprehensive approach to prevention and to recognition. So the last innovation I want to highlight is point-of-care ultrasound. And I'm going to do this quickly because I see my time is up here. So ultrasound is a really important component of routine care as both a screening and diagnostic tool throughout the antenatal, interpartum, and postpartum periods. WHO's 2016 ANC recommendations and also their 2022 ANC updated guidelines recommend one ultrasound scan before 24 weeks of gestational age for pregnant women. We know that ultrasound measurement gives us accurate estimation of gestational age. There are certain time-specific interventions during pregnancy for which understanding gestational age is vital. So like an example of this would be antenatal corticosteroid therapy, which is recommended for women with a high likelihood of preterm birth, but it's recommended in the 24 to 34 weeks of gestational period. So understanding gestational age can be so important. Routine antenatal ultrasound can help detect pregnancy states that we otherwise might miss, things like multiple pregnancies, placental previa. It can detect fetal anomalies, and it helps the family to really be able to plan effectively to deliver in a place that has the care that they need for their situation. It's important to acknowledge what makes point-of-care ultrasound different than traditional ultrasound and why this is particularly innovative and needed in low-middle income countries. So as compared to traditional ultrasound, point-of-care ultrasound is much more portable. It takes up less space. It can travel to the patient instead of the other way around. It may be more easily used by a range of clinicians. And the turnaround time for results can often be in real time and at the bedside. So all of these advantages can address a lot of the barriers to uptake of the traditional ultrasound machines. There are many different portable ultrasound products being tested. There may be some innovators here at this conference. We know that the potential of portable ultrasound is potentially groundbreaking. And Jhpigo is helping to promote the uptake of many of these portable ultrasounds, as well as the feasibility and acceptability studies, with integrating point-of-care ultrasounds into ANC delivery, service delivery. But the point I really want to drive home today is that ultrasound equipment is just one part of the system to reduce maternal and newborn deaths and stillbirths. What we need is a high-functioning system with portable ultrasound technology that also includes high-quality, essential maternal newborn health services across the continuum of care, capacity building that considers task sharing and patient safety, better experience of care, and consistent high-quality counseling, use of gestational age data for clinical decision-making, and strong referral systems and high-quality care to manage complications when they are identified by the ultrasound. Embedding ultrasound into a strong system is the only way to ensure that it will achieve clinical impact. So finally, the take-home messages I want to leave with you today around acceleration of uptake of innovations. This presentation was not meant to be a comprehensive presentation on how to scale innovations, but rather highlight a few lessons that we've learned through experiences that we've had at Jhpigo. So first of all, the first message is, let's think of product innovations as a critical piece of the entire puzzle. Innovations need to be embedded into quality and comprehensive care. Silver bullets will not work unless we think of them as part of a holistic package of care to support those products. Secondly, let's not recreate what we know works. We have many of the solutions and innovations already. Let's use them, let's bundle them, let's organize these innovations and optimize them for successful uptake. Third, contextualization of innovations and key stakeholder buy-in is key. We need to take the time to work with the end users to figure out the enabling set of ingredients, the recipes that will enable an innovation to succeed. And finally, strong partnerships are essential for accelerating progress. We need innovation work in the maternal and newborn health space should not be a competitive space. It should be a collaborative space. Let's use this time that we have over the next couple of days to really put our heads together, because we'll make more progress together.
So thank you for the wonderful talk, and I really appreciate the message that you had about there aren't silver bullets that are going to make change. It really takes improving and strengthening the system. I wonder if you have advice for local innovators. So we work with a lot of engineering students at universities where Nest is partnered, and they have really great innovative ideas. How would you advise them to partner with organizations like Jhpiego or other health system strengthening organizations to sort of move beyond that my technology is a silver bullet view into my technology as one part of a system that really needs to work more effectively?
Yeah, thanks for the question. I think going off of what Tor was showing us of how long it takes an innovation to scale, right? I think that, there are many great ideas, and often, we tried at the International Maternal Newborn Health Conference to not just pick innovations to showcase that were already at scale, but we tried to pick ones that were very early on in the thinking, right? Because it is harder when you're at that beginning phase. And I think one of the things I would recommend is for people to talk to those that are further along, talk to those that are further along in that space. Get ideas, share ideas. I think also, there is quite a bit of, I think, fatigue. There is innovation fatigue. I was recently at the ENAP EPMM meeting in Tanzania, and lots of the countries were just, when these silver bullets were presented, this app that can document this or that, they said, we need that newborn app, but we need it across the continuum of care. We need that to translate for the mother, for the newborn, for the child, So I think also as an innovator, thinking through putting yourself in the end user's shoes and trying to figure out what really makes sense, what's really going to be a comprehensive approach that is not just one sector, but covers many different sectors, is a really important thing to think about.
Following up on that question, which is really around how do we partner? So thank you for sharing how we could partner with your organization, but can you also expand that to talk about how we can partner with local countries? And as you pointed out, you do have to support not only that newborn, addressing that 50% we lose on day one in some circumstances, but how do we extend that to the mother, to the children, and look at additional health concerns that we may have?
Mm-hmm. Yeah. I mean, I think it's really important to have people boots on the ground, sitting in the US and having an innovation, it's going to be very tricky. So I think of partners like Nest360, that have a model on sustainability, right? Going into the country, but then identifying people that you can work with in that country, experts in that country, other people in that country that have the same interest as your innovation, and working through them to make, to make your innovation sustainable and embedded into a system.
Awesome. Thank you. Well, what a great opportunity to meet folks here through this event that we can have those conversations with. Thank you.
Thanks.
Thank you, Amy.
talking about my research about wearables for health monitoring. When we think about wearables, this is usually what comes to mind, right? And then when you think, they are pretty advanced already. Look at the number of features that they can measure in real time and continuously. There's so much research that we can do only using those devices, right? I know many groups here at Rice, they use this to make machine learning, artificial intelligence. My job is to take this, which is already pretty advanced, and combine with this type of point-of-care devices. Today, if you want to know, for example, your uric acid, glucose levels, you need to go to the pharmacy, and maybe each one of these costs around $50. And then it's very not convenient to be pricking your finger for every measurement you want to do. So my research is combining the devices that we saw previously with these point-of-care devices into one single platform that can monitor blood pressure, heart rate, and then all the stuff that we already know, plus the chemical information. But what I'm telling is that I'm not going to use your blood at all. I'm proposing to use non-invasive biofluids, such as sweat, interstitial fluid, tears for contact lenses, interstitial fluid, like those continuous glucose monitoring, already using those. So this is my research, right? And today I want to talk to you about 3 of my devices. One is for the ones for aspiring mothers, people like women who want to get pregnant. Right after birth is the second device, and the one for baby. So this is what we're going to see today. And then this is like a ring-like wearable device, where you have here, oh, it's not pointing. It doesn't work there. Okay. It is for collecting sweat. So you have the device around the finger. We can stimulate your sweat to come out. The device is going to collect the sweat, and it's going to monitor estradiol in sweat. And then with this, we were able to track the ovulation time. Here you can see 2 volunteers. At the bottom, in the plot here, you see sweat monitoring. At the top is blood, serum. And then at the very top is urine, one of those pharmacy testing. So you can see 2 cycles in the plot that correlates really well with the light green ovulation time. I like this work because it not only tells you like when you're ovulating, so if you want to intend to be pregnant, but we are also advanced this idea for menopause. You know, there are women who have to undergo like a hormonal like replacement treatment, and those are really difficult for the doctor itself to titrate. It is a lot of back and forth to the doctor telling, oh, my symptoms are getting worse, and then I need to increase the dosage. And then the most important part of this work here is there are like women that they have hypertension, they are obese, they are excluded from this treatment just because they need very close monitoring, you know, of the titration. So this can help, including those women also for the hormonal treatment. So that's really nice. So this is one of the works that I am currently working with for menopause, right? And then the other one, we talked in the beginning about like mental health, panic attack, and then I ask you, today, how do we monitor, how do we do the diagnosis of stress, depression, anxiety? It's just some questions, and then you have to feel like from 1 to 5, how do you feel? It's very subjective, right? So we want to propose something that you can actually measure, that you can quantify, and then you can have a better treatment and diagnosis. So when your body is under stress, your brain releases some chemicals that makes your organs to release some other chemicals, right? Makes your heart go faster, glucose, cortisol, all of this under stress is released to the body. The muscles, the heart also responds to the stress. And you start to sweat. When you're under stress, sweating is everywhere, right? And then the nice thing about this is that sweat carries all these other chemicals that is being released with this fast, dynamic event that is stress, right? So this continuous variable is interesting because you can monitor dynamic, fast changes. What we are proposing is to monitor the largest number of analytes that we can in a single device, So we can do a biomarker signature. We can see when we do this type of stressing, this is how all of these parameters change. This go up, this go down, and then we can do some machine learning, try to classify. I give you some example of the measurements that we have. For example, the first is like very common to induce stress, is to put your hand in cold water with ice. And then this induces stress. And then we were monitoring different types of stress, right? During like a VR game and also physical stress during exercise. And then you can see that all the parameters that we have there, they change differently. And then we can use this as a way to do biomarker signature. This is also one of the things that I am pushing very hard, like here at Rice, because we have a lot of people working with machine learning, AI. And one of the limitations I'll tell you about sweat analysis is that sometimes it does not correlate really well with blood. But with this kind of approach, this is not a problem. You just want to see if it is going up and down, and then like what is going up and down, you know. So concentration, really like accurate measurement of what the analyte is not that important because we are measuring so many other parameters, and then we are having the barcode of the disease. This is important for healthcare, for some types of cancer, for any other disease that does not have like single biomarker, right? So this is the second work that I want to talk about. And then the last one is one of the I really like. I remember when I started working in the field, I was pitching my family to see if they understood my research, right? And then I would say, oh, I work with non-invasive wearable devices. My dad, he has type 2 diabetes, and I asked him, Dad, does it bother you to have to prick your finger all the time? And then he was, no, not at all. Why? And then damn. I need to rethink about how I'm going to pitch this type of research, right? And then I was thinking, who would care about like a finger prick and pain and then eliminating this to be non-invasive? And then they would care very much, right? Every baby that is born needs to do the blood testing in the food, but some of them more than others. There are something called neonatal diabetes, is when the baby is born, they cannot control their glucose levels really well. It keeps super low or super high. And then they have to do this type of testing every hour for 12 hours. So imagine. And then there's a lot of finger pricking. And then when baby grows in this type of stressed condition, it has been shown that their development is going to be affected just because of the stress they undergo in the first hours that they were born, right? And then there's a lot of children who actually has type 1 diabetes. Type 1 diabetes is diagnosed when you are about like 6 months old. So there are babies, there are toddlers, there are children that they do have to do fingerprint, they do have to use the needle for the continuous glucose monitoring, right? So we were thinking how to help these guys. My dad doesn't care to print their finger, but we do care about them, right? And then we come up with this really nice idea, was to put like the biosensor into the pacifier itself. It was really simple, really low cost. We just got like a commercial pacifier, and then we did like a channel that is just allows flow to go in one direction using like a simple stop valve mechanism. And then it would collect saliva that is pumped just because of the movement of the mouth. Take this outside of the baby mouth. So all the monitoring is happening outside of the body, not inside of the mouth. All the electronics and sensors are outside, and then the signal is wireless to the phone, for example. This is just to show overall idea of the pacifier, the device. Here we have the part that actually collects saliva. The channel, it is like unidirectional, and then allows saliva only to go inside. And then here we have those simple, like screen-printed, very low-cost sensors that we can tailor if you want to measure glucose or if you want to monitor another disease, at birth. You can tailor that one. But we are using enzymatic sensors, which is the one found in the continuous glucose meter and then in the test strips, like that is commercial. And then all the electronics, as I said, is outside of the mouth, outside of the pacifier, and then we pull out saliva in this spongy-like, and then all the system would have to be replaced maybe once a day. Once a day you take the sponge, once a day you replace the sensor. And this is one of the example of data that we had. So control up there is when you have no enzyme at all, no detection mechanism, just to see if the movement of saliva going up inside and out would interfere in the measurement. And then in the blue line is like fasting before meal, and then in the red line is like right after meal. This testing were like, I wanted to put a picture of me with a pacifier, and then I said, nope, it can be used against me. So yeah, I'm really proud of this work because right after we published it a while ago, there were so many works using the same platform. So people were monitoring the actually movement of the mouth, you know, how it's sucking to the pacifier to see if there's some correlation with diseases and stuff. Temperature sensor over there, it is important too. And then it's important to monitor glucose, even if the baby is not sick, because you want to know if it's crying because it's like hungry or is in pain, or you can have some kind of idea with this type of device. Yeah, this was it for me today, and thank you very much.
So you showed an example of how these sensors could be used with neonates, with newborns. What, if any, thinking, have you thought about maternal health? Have you been speaking to any doctors?
Yeah, like we were talking when we developed this work with clinicians, pediatricians from UC Santa Barbara, and then they were really interested in start like some pilot study. And then she did said that you do have to prick the foot of the baby many times. So we were almost going to that pilot study, but then one of the students that were like really actively working had to leave. But it is promising. There is other study that we did went forward with the same platform. And then also for the mom and baby, I don't show here, but we also have like some portable ultrasound, but for measuring blood pressure. So we do have like some piezoelectrics. When it vibrates, sends an ultrasound like 4 centimeters down the skin, and then you can monitor how the artery is opening and closing. So from that, you can infer about blood pressure, which is also wearable. You can wear like in the belly to monitor your own blood pressure or vitals of the baby. So that was really interesting. Thank you.
Very exciting.
Thank you very much for your presentation. I thought it was very interesting. My question relates to your last device where you were showing the dummy, which I think is fascinating, and I think that's great. I just wonder, for countries where dummies aren't used, and the fact that we're obviously trying to promote babies going on boobs and kangaroo mother care and things like that, would there be a way of creating a device which could fit onto the boob whilst the mum suckles? So whilst the baby suckles. So, and obviously that adds complexity in terms of the fact you've also got mum.
Yeah.
So you've got mum and baby. But is there a way that you could change the device slightly so it could then be used for mums who are breastfeeding wherever in the world?
There is really interesting idea. The only thing we need is to collect saliva. So if you have some type of like a wearable sticker, really like comfortable to wear, that is a microfluidic only. Collecting saliva, then you can do all the analysis that you are doing with the pacifier. So I think that would be really possible. In this direction, I also forgot to mention we are worked with some devices that you put on the bra, and then when you have like milk leaching out, and then you can monitor parameters of the milk, especially for moms who are breastfeeding, and then they're, I don't know, want to drink but are concerned, or taking medication, it is concerned to go to the milk, then they can be more peace of mind to know that they're not taking it to that baby. But that is really interesting. This is why it's important, this type of conference. And then Amy was talking about to think like globally, like in a large scale. We were just looking at a pacifier, but I didn't know that people maybe not have access even to a pacifier. That's interesting. Thank you.
Hi, I'm Msandeni from Malawi. Excuse my ignorance, but I could see how you could collect tears. You've nicely explained how you get sweat, how you get saliva. I just can't wrap my head around how you're getting the interstitial fluid without being invasive. So just keen to know.
Yeah, that is really interesting question. Thank you. So I don't know, a long time ago, some of you may remember the glucose watch. There was a watch that was using what's called reverse iontophoresis. What is that? You have like 2 electrodes on your skin, and then hydrogels between the skin and the sensor. And you apply some voltage or some current to these 2 electrodes. That was actually a glucose watch. The interstitial fluid, it has a lot of ions, sodium, chloride, and stuff. So when you apply some voltage, you're gonna pull out the positive ones to one side, the negative ones to the other side, and then you're gonna create a flow, a net flow of interstitial fluid in one direction or the other, right, depending on the cathode or the anode. So you can actually extract glucose and other small molecules with this. Some things called iontophoresis, which is related to the movement of ions. So you apply current, you pull out ions from out of your skin without piercing it, without breaking the skin at all. Yeah, that is interesting. Thank you for the question.